I'm just going to talk to you for a few minutes about some things, what lies beneath. And so today, so far, we've been talking about sort of the clinical manifestations of sickle cell disease. What I'm going to talk about is actually some of the stuff that goes on that isn't always necessarily picked up and what we can do to do things differently. So, historical child abuse, domestic abuse of men and women, suicidal ideation, psychosis, self-harm, obsessive compulsive disorder, depression, anxiety, bereavement, homelessness and unemployment, and a deep mistrust, unwanted pregnancy. In the Red Cell Clinic, this is not Ian's psychological medicine clinic, this is the Red Cell Clinic. And you're going, what? Yes, really. So I just wanted, these are some of the things that we've picked up as a team, or me as a nurse over the last 6 years that I've been working in this job. And I just thought it was time for us to be a bit mindful about that actually the real world also happens to our patients. And we need to be, we have an opportunity to be more attuned to that and be able to work with them to get them the help that they need. So why are people bringing these issues to us? Probably because we offer a holistic service. We may well have much more time. We're probably more accessible than any GP service in the country at the moment. There's a level of trust. They feel listened to. They feel that they're being heard. And actually, for the individual, for them, maybe they've reached that stage of readiness. You know, it's time to get help. We talk about stages of readiness in child development a lot. I don't think we talk about it enough in sort of the areas of sort of people's psychological support and harm. And I think there's something really important to do that. Ian will probably tell me there's a truckload of literature, but I haven't looked. So we've talked about what happens and perhaps why this start to raise it. We're just going to have a look at a bit about the where, when, who, and then and how. So when? As someone sitting in the clinic, it's like looking for those clues, being aware of those clues, what's not being said, what doesn't quite add up in this story that you've just been told. What is not being said? That change in body language when you shift onto how things at home or how things at work. The silence. How have things been? Deadly silence. And we all know the deadly silence. We've also got a clock ticking going, okay, you've got the next patient coming in 3 minutes. So, Manuel, you'll need to time for yourself. I locked myself out. The sudden tearfulness that comes out of nowhere, the sort of anger around everything, that flat affect. You know, you can't raise a facial expression out of an individual. And usually non-communicative. You know, lots of our patients are very chatty, they like to tell us what's going on, and all of a sudden there's deadly silence. Signs of harm. You know, in adults, we're not really very good at looking at people. You know, and with COVID, we've not had anybody in the clinic for 2 years sometimes to, you know, assess their spleen and, you know, maybe have a look and see what else is going on with them. And then also new repeated attendance or admissions. You know, some of our patients go for years and all of a sudden there's a run, 4 or 5 admissions. What's going on? Where do these things come up? They come up in the clinic, in the day unit when you're down having a chat, follow up after the ward round because actually that's not quite the story you told me when you came in. I've heard something different now. And things also come up on telephone and video calls, actually. And then who? You know, the person to whom this is being declared, there's clearly a trust in you and a readiness to actually maybe not deal with it, but actually tell the story, which is really important. How do we go about this? Now, this is like going to tell you this in 3 minutes, and clearly this is not going to fix all of our communication issues as healthcare professionals, but it's just some things to think about. So listen. I think as healthcare professionals, as I'm doing now, we do a lot of talking and we don't actually turn our ears on. And actually, I think switching it around to work with the patient's agenda, you know, actually, what would you like to talk about today when you start the clinic, rather than, oh, how have you been? Have you had any pain? Are you taking your drugs? How are your vaccinations? All of those kinds of things, actually flipping it around a bit. So actually, the patient starts to get the idea that actually, I can talk about anything here. Actually, that just loves me. That's what I like to talk about today. So listen. Stop talking and take notice. Allow for that silence. Healthcare professionals hate silence because it means we're not doing anything because nobody's talking and nobody's moving. So we just need to allow for that and allow that to sit because actually eventually the patient will start to speak. Use open questions. Tell me a little bit more about what does dangerous at home for you at the moment mean? So I can understand a bit better. Can you describe that situation a bit more? You know, be really open. Do some paraphrasing. So this is what I think I've heard, or just so I'm clear, or just to clarify, so you kind of feedback, so you actually give the patient the opportunity to go, well, actually, this needs to go with that, or actually, no, you haven't got that quite right, it happened in this way. And then take the time, and I know that's really difficult because the NHS is very busy, but actually don't give the impression that you need to run to the next patient as soon as the patient comes in the door. Unfortunately now in Oxford we don't have any notes. It used to be the stack of notes sitting on the desk that people would go, oh gosh, okay, I'm the first one off that pile, and there's another 15 to go, so I clearly can't talk to anybody about anything today. And then ultimately make some good notes because you're going to need them. So next step, you want to summarise to the patient. So just to summarise what you said today, have I got this right? What would you like to do from here? This is not about you running away going, oh yes, I'm going to fix all this, I'm going to run around, I'm going to sort it out. It's not about that. It's about what would you like to do from here? How should we take this forward? How would you like me to help? Yeah? Because actually it's their problem. You can't take it away, but you can offer the support to help them with it. It's really interesting to, especially where people are suffering from really quite severe anxiety and depression, some of the stuff that I've learned through my clinical supervision over the last few years is actually talk to patients about what they've experienced before. You know, is depression and anxiety something that's been a common theme in their life? And if it has, what did you do? What helped before? Things that worked in the past. And it's really helpful to try and draw them back to think about actually when they were in a time of crisis before, how did they get out of that? So they can, in a way, it's a bit like that neuroplasticity we were talking about before, it's re-invoking those pathways for things that did work. So it turns this into a positive conversation. And what kind of plan did you have before? Because they will have had plans. Really must declare safeguarding requirements. You know, we all know that, we're all trained, but actually just sometimes from your depth of it, you kind of don't switch your mind into the fact that I need to talk to safeguarding about this. You switch your mind into, okay, I need to listen, need to document this, what we're going to go forward. You need to talk to the person about having permission to share. Is it okay if I discuss this with Ian or your GP or you know, your psychologist? And be honest about your skill set. It's okay to say, look, I don't know how to take this forward. Thank you for telling me. Let's get some help. Yeah, or I'll find out. And agree a plan. Okay, there's nothing worse. It's a bit like when you take your car to the garage and the guys go, oh yeah, we've got this wrong, this wrong, this wrong, and then you go and go, I have no idea what the plan is, and I have no idea how much it's going to cost me. Your patient, having declared these issues to you, needs to go away with a plan. It kind of holds it all together with them. So, you know, what are you going to do as a healthcare professional? Are you going to contact a psychologist, speak to the psychiatrist that's on site, speak to the specialist nurse if you're the doctor? You know, you're going to call safeguarding, you're going to talk to the GP. Are you going to signpost to other services? What's the patient going to do? And again, review with them what's worked in the past. Make sure that they've got some safety netting. So don't let them leave the clinic without a plan who to call if things get really bad at midnight tonight. You know, you're not there 24 hours a day, they can't call you. And even if you are there 7 hours a day, 8 hours a day, actually you're in clinic, you're seeing other patients, you're on ward rounds, you're not there. So actually, who are they going to call? Who are they going to speak to at home? And ensure that they, you know how to get out of our support. And then agree the next step. So you've kind of talked all this, they've raised it, you've given them a plan, and then they go, okay, do I now ask what happens next? So it's about making sure that they know what the next step is. And get the patient to write their plan down. Ian will probably talk to us about CBT at some point, but actually one of the key elements of CBT is actually, many elements, is actually the individual writing down their own plan so that they own it, it becomes concretized, it's written down in their own words, and actually it gives them something to hold on to. I have a plan, we can do this. Don't be tempted to write it down for them, okay? It's about them owning that. So follow up, make sure you do your actions, make sure you do as you say you're going to do, and that they're followed up, because referrals can sometimes take quite a long time to come through. Make sure you've got a timely follow-up with the patient. and have a clear purpose to check in. So you don't want to go over what's been discussed. You want to check in, find out how things are today, and thank you. And then update on your plan and where things have been, and check in where they've been, how they've been going. Review the written plans for patients, find out what's been working, what hasn't been working, maybe think about other things together that might help bridge that gap until they can get some support. And ensure you've got another check-in agreed. That can be until they can be picked up by the appropriate service. What we really don't want to do is for these people having spoken to us and trusted us, is for them to then feel abandoned. Actually, abandonment for our patients is really very common. So, your skill development. I just had a quick run around last night. I'm really sorry. Folks at home, you've got a beautiful presentation here. It's turned to green mud. Have a look at Health Education England. There is a massive number of modules that you can do, e-learning. It's called ELFH. There's a fantastic one on mental health awareness, on communicating with empathy, which actually focuses more on end-of-life care, but actually empathy is empathy. It doesn't have to be end-of-life care. There's a great session on talking about suicide, how you ask people about their thoughts and what's going on for them. BMJ Learning Online also has fantastic 1-hour module that's free on motivational interviewing, which is about turning around your consultation so that actually consultations from the focus of the patient. We get what we need as healthcare professionals as well, because we use this model quite a lot in our clinics. They've got another great module on suicidal ideation and self-harm and aggressive or disturbed behaviour. Historically, with cancer MDTs, one of the peer-reviewed standards was that everybody who was in a cancer MDT had to undertake advanced communication skills training. And actually, that's offered in our trust under our hospice. As long as you mention the words in our trust, end-of-life care, anywhere in the application, and it doesn't mean to say you have to work with cancer patients. Actually, all of us deal with patients at some point, be they children or adults, who need end-of-life care conversations, and they'll accept it, and you don't need to pay. And that's been a fantastic program. Think about getting some collegiate feedback or clinical supervision. Actually, do you have psychologists you can speak to about the things that are coming up in your clinic and how best to address them? Actually, is there some team teaching that we could be doing to think about those communication skills? Think about maybe do some shared observation, and yeah, just take some time to think about what it is that you might need as an individual, because communication skills are one of those things that you develop over a lifetime. You can't just pick up a package neatly off the Amazon shelf, plug it into Sandy, and you're a perfect communicator. It's something that takes time to build, and it's very situationally dependent as well. So, in summary, listen, don't be afraid to ask. If you work with your patient, follow the patient. Actually, you won't get this wrong. Make a plan with your patient, get some help, both for you and your patient, and then think about your skill set so that you can think about actually how you can develop going forward. So, any questions?